Hello and welcome. I'm Judy Heidebrink. I'm a neurologist with the University of Michigan Alzheimer's Disease Center, and I'll be talking today about dementia biomarkers. Let me start with my disclosure for this presentation. I receive research support from Eli Lilly, which manufactures a compound called Florbetapir. Florbetapir binds to the amyloid plaque. That's a hallmark of Alzheimer's disease, so it's one of the agents used in brain imaging to identify Alzheimer's pathology. I'll be talking about this as a biomarker, and I do receive research support in which Eli Lilly provides the Florbetapir compound as well as other financial support for the clinical trial. So here are the objectives for this presentation. My hope is that by the end of the presentation you'll know what we mean when we talk about a biomarker and why biomarkers are needed in dementia, that you'll have an understanding of the biomarkers that are used most often in assessing dementia, and something about the usefulness of each biomarker for specific causes of dementia. So let me start with a definition of biomarker. It's a shortened form of biological marker, and the NIH work group on biomarkers defined them as characteristics that are objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacological responses to a therapeutic intervention. So for example, you could think of body temperature as a biomarker because you can evaluate how body temperature might vary from one individual to the next under normal biological processes, how an elevated body temperature might be a sign of a pathogenic process like some type of an infection. And you could also evaluate whether a treatment for that infection led to a normalization of body temperature and whether that corresponds to overall recovery of the individual. All right, so why are biomarkers needed in dementia? Well, there are several reasons, and I've just listed 3 of them here. First has to do with the diagnosis of a specific cause of dementia. We do have testing in terms of brain imaging and laboratory tests that can evaluate for certain causes of dementia, but for the most common causes of dementia, the neurodegenerative dementia such as Alzheimer's dementia, the Parkinsonian dementias, or frontotemporal dementia, the diagnosis is based on clinical grounds. We use the presence or absence of specific signs and symptoms, things like cognitive changes, behavioral changes, and physical or motor changes to determine what type of dementia an individual has, and in the end we make a clinical diagnosis. Now that diagnosis can either be confirmed or refuted by post-mortem brain examination looking for the hallmark microscopic changes associated with the specific type of dementia. And unfortunately, even at the best academic centers, a clinical diagnosis of something such as Alzheimer's dementia is not 100% accurate. It's more like 80 to 85% accurate. So can biomarkers help us be more accurate in determining the specific cause of dementia so that we can begin appropriate therapies directed at that specific cause? Or what about individuals who don't have dementia now but might be at risk for developing dementia in the future based on family history or potential genetic risk factors? Can biomarkers tell us more about who is at highest risk or who may be at lower risk of developing dementia in the future? Particularly, people may have very early symptoms that don't really warrant a diagnosis of dementia. And another area where biomarkers can be quite helpful is determining whether a dementia treatment is working. Well, you might ask, well, can't we just determine that on clinical grounds? Can't we, for example, in a study of a medication to help Alzheimer's dementia, administer the medication and see if individuals who take that medication improve in their thinking abilities? And that, in fact, is what's often done in a clinical study, but there can be many other factors besides the effect of the treatment that can end up affecting whether someone is doing better or worse on a cognitive test, for example. So this picture just illustrates the performance of a group of individuals, all diagnosed with Alzheimer's dementia. They all scored within a fairly tight range on a cognitive measure at the very beginning of this evaluation, and they were retested using the same cognitive test 6 months apart. So they were all given the same test 6 months later, another 6 months later, there was a gap, and then a year later. And each line or set of circles represents the individual performance. of someone undergoing the testing. Now, importantly, none of these individuals were receiving any type of treatment. This was just simply what happens to their cognitive test scores over time in individuals diagnosed with Alzheimer's dementia. And you can see as a group there's a general trend downwards, but there's a lot of variability even within a given individual. This individual seemed to do better after the first 6 months and then worse over time, whereas this individual had a big drop and then bounced back up. Do we really think their Alzheimer's disease worsened and then recovered, or that this individual improved and then, or was there some other factor in terms of how they performed that day? Maybe change in how much sleep they had the night before, whether they traveled a great distance before their testing, or any number of other things that might have influenced their test performance that wasn't really truly a measure of the change in their Alzheimer's dementia. So other ways of evaluating in terms of looking at the biology of the disease may be more accurate in terms of looking at changes over time. So what are the types of biomarkers that are being looked at in dementia? Well, cognitive tests themselves can be thought of as a potential dementia biomarker, but as I mentioned, they do have limitations because many other things other than the dementia itself can affect an individual's performance. A variety of substances in the blood and other body fluids have also been looked at as potential dementia biomarkers. Sometimes the dementia biomarkers are not directly assessing the dementia itself in terms of cognition, but other features that are associated with certain dementias, like changes in smell that can be associated with some of the Parkinsonian dementias or certain types of sleep disturbances. Other biomarkers are looking at how an individual responds to the administration of certain substances. Years ago, there was an eye drop test that was touted as a potential diagnostic test for Alzheimer's dementia based on some very preliminary work that unfortunately didn't hold up as a diagnostic test. Probably the newest version of something similar is something called the peanut butter sniff test. There was an investigation of whether one could smell peanut butter held about a ruler's length away from one's nose as a potential marker for the presence of Alzheimer's dementia. Unfortunately, it didn't hold up either, but just a wide range of potential biological processes are being examined for their potential role as dementia biomarkers. And I'm going to focus just on three major categories of biomarkers in dementia, those involving structural imaging, and I'll focus specifically on MRI, looking at the shape and size of certain structures of the brain. I'll also talk about molecular imaging, which evaluates brain processes more at the cellular or molecular level, and I'll be talking about PET scanning or positron emission tomography. And I'll also talk about cerebrospinal fluid, or CSF, the fluid that bathes the brain and the spinal cord, and how markers in the spinal fluid may tell us about specific dementias. So let me start with MRI as a potential biomarker for dementia. And if you want to learn more about MRI in general in dementia, there's also a separate webinar about MRI imaging in dementia. But in general, because dementias affect the brain, specific dementias affect the brain in different regions, you can see different patterns of shrinkage or atrophy depending on which type of dementia is occurring. So here are some representative MRI images from different individuals who have either different types of dementia, or there's a control individual in the top left. And just to orient you to these pictures, these are what are called coronal views. It's as though the patient is, or individual is facing us. And so off to the sides here would be their ears, so that's about the level. If this individual is looking at us, this in fact is going to be the left side of the brain, and what looks like our left is really the right side of the brain. And so here's just a normal coronal view of the brain, a coronal MRI. We do see some wrinkles sort of on the surface of the brain. In individuals with dementia, you'll see those wrinkles deepen as there has been accelerated shrinkage or atrophy of the brain. You can see that to some extent in an individual with dementia with Lewy bodies, but it's even more marked in the individual with Alzheimer's dementia. And particularly if you focus on this area here, the medial temporal lobe, or a structure called the hippocampus, you can see a lot of shrinkage in this individual with Alzheimer's dementia compared to the individual with dementia with Lewy bodies or the normal control individual. On the bottom are a series of MRIs from patients with different subtypes of frontotemporal dementia. So on the bottom right here is an individual who has the subtype where they have particular difficulties in generating speech, the non-fluent or agrammatic variant of what's called PPA, or primary progressive aphasia. There's a lot of atrophy in the frontal lobe here on the left side. This individual has what's called a semantic dementia, another subtype of frontotemporal dementia, where the atrophy is selectively in the temporal lobe, and again, asymmetric, much more on the left than the right. And here's an individual with what's termed the behavioral variant of frontotemporal dementia, and they have more symmetric atrophy and predominantly in the frontal lobes, more so than the temporal lobes. So again, across these different cases of dementia, there can be some variation in terms of the regions where atrophy is most prominent. So are these helpful biomarkers for distinguishing types of dementia? Well, the specific MRI biomarker that's been looked at most often is looking specifically at that medial temporal atrophy. And here again, just sort of close-up views of that region. And research studies have looked at the degree of atrophy in the medial temporal lobes, rating that atrophy either by quantitative measures, using perhaps computer-assisted algorithms to trace out this area and measure its volume, or qualitative methods by simply looking visually and saying how much shrinkage on a numerical scale. So this shows something called the Shelton scale, where 0 would be considered normal, 1 a mild degree of atrophy, 2 more significant, all the way to 4 a severe degree of atrophy. And so there have been studies comparing MRI scans with individuals with different types of dementia to their post-mortem autopsy findings. And it looks like the presence of significant medial temporal atrophy has a reasonably good ability to distinguish Alzheimer's dementia from dementia with Lewy bodies, or individuals who have more vascular cognitive impairment or dementia, since neither of these is particularly affecting the medial temporal structure. So in one study, for example, individuals with Alzheimer's disease tended to have a medial temporal atrophy rating in the 3 to 4 range on average, and in DLB and vascular cognitive impairment is closer to 1, 1.5. However, the studies have been less promising in distinguishing Alzheimer's disease from frontotemporal dementia because, as you might expect, there can be a fair degree of temporal atrophy in the frontotemporal dementias, and somewhat disconcertingly, it may not have perfect ability to distinguish Alzheimer's disease from someone who simply has normal aging. Our brains shrink as we age, and if you take someone on the older end of the age spectrum, they may have a significant amount of atrophy without the presence of Alzheimer's pathology. So potentially helpful depending on the clinical question. There have been further studies suggesting that rather than taking a single area like the medial temporal lobe, you might want to look at a different area depending on what the exact clinical question is. So for example, medial temporal atrophy may be well able to distinguish individuals with Alzheimer's dementia from dementia with Lewy bodies, but if the question is Alzheimer's versus frontotemporal dementia, looking for atrophy in posterior regions would be more helpful, since that's more likely to occur in Alzheimer's dementia and much less likely in frontotemporal dementia. Let me turn now to a discussion of some of the functional or molecular imaging biomarkers. And the first one I'll focus on is a general measure of brain activity or metabolism. That's a PET scan looking at glucose metabolism using a marker called FDG, or fluorodeoxyglucose. So just in brief review, the way PET imaging works is that an individual is given a small dose of an agent that is labeled with a radioactive tracer. And so where that tracer is taken up in the brain can be detected by using a PET scan to determine where anatomically the radioactivity is being detected. And in these particular scans, individuals were given a radio-labeled form of glucose to follow where glucose, which is the brain's major fuel, where it's being taken up and being used by the brain. So in a sense, a PET scan looking at glucose uptake is showing where is the brain more metabolically active, where is it less active. And in general, even if you're resting, the thinking parts of the brain have some level of baseline activity, but in the presence of certain dementias, there is a reduced level of glucose metabolism. Now the scans here shown in the picture, they're not actual measures of glucose uptake. These are statistical maps to say where is this individual's pattern of metabolism most different from a normal control. So the brightest colors show the greatest degree of abnormality in comparing this individual to a normal control. So the first column of images depict the right side of the brain, sort of looking from the outside. The next column is the left side of the brain looking from the outside. The last two columns are looking at the brain from the inside out, so the right side medially and the left side medially. And in individuals with Alzheimer's disease, you tend to see the greatest reductions in glucose metabolism in the temporal and parietal regions, shown here in red in the right hemisphere, also in the left hemisphere, less so in the front. So these are the two halves of the brain with the front parts of the brain facing one another. So there's less of a change in the front part of the brain. If you look on the medial views, there's a characteristic change in an area called the posterior cingulate. You can see that in both hemispheres. Individuals with dementia with Lewy bodies tend to have a similar pattern in terms of temporal parietal and to some degree frontal changes as well, but there's also more hypometabolism posteriorly in the occipital lobe. So you'll see changes down here that you're not seeing in the individual with Alzheimer's dementia. Not surprisingly, individuals with frontotemporal dementia show the greatest reductions in glucose metabolism in either the frontal lobes of the brain, right and left, or in the temporal lobes of the brain, right and or left. So how helpful are these sort of signature patterns of glucose metabolism in distinguishing one cause of dementia from another? So if you look at studies where FDG PET imaging has been used and compared to post-mortem confirmation of diagnoses, the accuracy, if you look at for the PET signature of Alzheimer's disease and comparing those with Alzheimer's disease versus a different type of dementia, the accuracies range somewhere between 80 to 90+%. And it depends a little bit on what your comparison group is. So if you're comparing those individuals who had autopsy-confirmed Alzheimer's disease versus any other type of dementia, the accuracy of the PET signature pattern was about 80%. If you're looking only more specifically, is it Alzheimer's versus frontotemporal dementia, the accuracy looked even higher at 93%. And in fact, Medicare does cover an FDG PET scan if the clinical question is, does this individual have Alzheimer's dementia or frontotemporal dementia, recognizing the added value that the FDG PET scan can provide in trying to distinguish those types of dementia. So it may be added accuracy, again, depending on the specific clinical question, but still not 100%, unfortunately. Well, the other types of functional imaging involve tracers rather than just tracking metabolic processes in general. There are tracers that can bind to specific proteins in the brain that are associated with specific causes of dementia. So there are now several tracers that specifically bind to the beta amyloid when it's found in neuritic plaques in the brain. And the Pittsburgh compound B, or PIB, was the first compound in use for this purpose. And these are some representative PIB scans. Now these scans are showing actual binding of the PIB agent. So areas that are red reflect areas where the PIB compound has bound to amyloid in the brain, and it's being demonstrated by the brighter signal here. An individual with Alzheimer's disease tends to have the uptake of the compound and binding around the cortex. An individual with frontotemporal dementia does not show that level of binding. There's just some non-specific uptake down in the white matter. And individuals with dementia with Lewy body can show some degree of PIB accumulation because at autopsy, individuals with Lewy body dementia often also have amyloid plaque pathology. So amyloid scans can be, quote, positive in individuals with dementia with Lewy bodies because of their associated amyloid plaque pathology, would be expected to be positive in individuals with Alzheimer's dementia, would not be expected to be positive in individuals with frontotemporal dementia. Another PET tracer that is used is called DTBZ, and rather than binding to amyloid, this binds to a protein found within dopaminergic neurons, and so it can be a marker of the integrity of dopaminergic neurons. And those neurons are affected in individuals with dementia with Lewy bodies, where you see little uptake of the tracer, but not in individuals with Alzheimer's dementia, where you see a normal uptake of the tracer. And frontotemporal dementia can be associated with some degree of Parkinsonism and can be associated with some reduction in uptake of the DTBZ tracer. So, in a study by Roger Albin and colleagues, they looked at individuals with early suspected neurodegenerative dementia or cognitive impairment, and all these individuals underwent amyloid PIB scans and DTBZ scans, and their PET scans were classified into a suspected diagnosis based on the PET scan results. So if there was PIB accumulation but a normal DTBZ, that was considered an Alzheimer's scan pattern. If there was a normal or slight accumulation of PIB and reduced DTBZ accumulation, that was considered a pattern of DLB. If the PIB scan was normal and there were only mild or no changes in the DTBZ scan, that was considered an FTD pattern of PET imaging. So how did the PET classification compare with the clinical classification in 93 subjects in this study? In general, there was reasonable agreement. Most of the individuals who had a PET imaging diagnosis of Alzheimer's also had a clinical diagnosis of Alzheimer's. Same for DLB, often for FTD, but in red you can see where the differences are highlighted. So these are where there's a mismatch between the PET imaging diagnosis and the clinical diagnosis. And the real question is, who's right? Is it the clinical diagnosis or the PET imaging diagnosis? And these patients are, some of them are just now coming to autopsy, and in general, there's been a higher correlation between the neuropathology and the PET diagnosis than the clinical diagnosis. So these types of PET scans may really be able to tell us what's going on at the microscopic level to either confirm or refute a diagnosis of a specific neurodegenerative dementia. And let me turn to the last biomarker I'll discuss, and that's cerebrospinal fluid. As you know, many of the neurodegenerative dementias have accumulation of abnormal forms of protein in the brain, and some of these can be measured in the spinal fluid. Unfortunately, we don't have good spinal fluid measures for some of the proteins that accumulate. So we don't have good spinal fluid markers, for example, of the alpha-synuclein found in the Lewy bodies, or for some of the proteins that accumulate in the frontotemporal dementias. But we do have reasonable markers for the plaques and tangles of Alzheimer's disease. So tangles are composed of a protein called tau, and in particular the tau tends to be hyperphosphorylated, so you can measure the level of tau in the spinal fluid, and it tends to be elevated in individuals with Alzheimer's dementia, and particular phosphorylated tau is elevated. If you measure beta amyloid in the spinal fluid, interestingly and perhaps counterintuitively, it's actually reduced. The thought being that the beta amyloid is accumulating and depositing in the form of the amyloid plaque, so less of it is available to circulate or flow through the spinal fluid. So when you measure it in the spinal fluid, that's the soluble A beta, and it's reduced in individuals with Alzheimer's dementia compared to those without Alzheimer's dementia. So how well do these spinal fluid markers of tau or beta amyloid distinguish Alzheimer's from other causes of dementia? Well, this table shows the results of spinal fluid analysis in individuals coming to a memory clinic with concerns about their memory or thinking. All of them underwent lumbar punctures to evaluate the spinal fluid, and measurements were made of their beta amyloid level, their tau level, and their phospho-tau specifically. And these are the results based on their clinical diagnosis. So about half of them were clinically diagnosed with Alzheimer's dementia. About a quarter or so were diagnosed with other types of dementia, but a sizable percentage were also diagnosed with psychiatric disorders, and a fair number with just subjective memory complaints without any evidence of a specific dementia process clinically. And so that group, the subjective memory complaint group, or SMC, was used as the reference group. And on average, comparing levels of A beta among the other groups to those with just subjective memory concerns, those with Alzheimer's dementia had much lower levels on average of A beta, but you also saw some reductions across some of the other dementia categories, but not in those who were felt to have psychiatric conditions. Tau was increased in those with Alzheimer's dementia, but again, could be increased in some other processes, particularly processes associated with rapid loss of neurons, like the prion diseases, Creutzfeldt-Jakob disease. Phospho-tau was elevated in the group with Alzheimer's dementia, less often elevated in any of the other diagnostic categories. Now again, these are clinical diagnoses, not pathologic diagnoses. Well, if we look as across the different diagnoses, how often did you see a combined pattern of low beta amyloid and elevated phospho-tau, sort of an Alzheimer's biomarker profile in the spinal fluid? So in those clinically diagnosed with Alzheimer's, it was the vast majority, 90%. The thought being that the 10% who did not show an Alzheimer's biomarker profile might actually be misdiagnosed with Alzheimer's dementia. Again, this awaits pathologic confirmation. But we did also see, or this study also showed, some degree of Alzheimer's-like profiles in the spinal fluid in individuals clinically diagnosed with other causes of dementia. Again, these could be misdiagnoses or it could be mixed pathologies. And in fact, at least one case came to autopsy in a patient who had a primary diagnosis of a frontotemporal dementia at autopsy, but had some low levels of Alzheimer's pathology as well, which may be what the spinal fluid was picking up. If we look all the way at the bottom, though, those individuals who were felt to only have subjective memory complaints, no clinical evidence of a specific neurologic condition, 12% of them showed a spinal fluid profile that looked like someone with Alzheimer's dementia. And compared to those with subjective memory complaints who didn't show that Alzheimer's profile, the individuals who did were on average older. So it looks like there may be some age-related prevalence of an Alzheimer's profile in the spinal fluid. Well, is that true if we look at other biomarkers? Do we see changes simply with aging? And the answer is yes. If we look at markers of amyloid accumulation, so if we go back to our PET imaging using an amyloid marker such as Florbetapir and look at how often an individual has a, quote, positive amyloid scan, these are the results of nearly 1,000 individuals participating in something called the Alzheimer's Disease Neuroimaging Initiative, or ADNI, and these are older individuals who either have normal cognitive abilities or a diagnosis of Alzheimer's dementia or something in between, what we call mild cognitive impairment. Not surprisingly, again, the vast majority of those with Alzheimer's dementia do have an abnormal Florbetapir scan, suggesting that in fact these individuals do have amyloid pathology going on in the brain. But nearly 30% of those with normal cognition also showed an elevated level of amyloid accumulation as measured by the Florbetapir scan. And those with mild cognitive impairment fell somewhere in between. So how well do these different biomarkers correlate? We've seen spinal fluid markers suggesting maybe 12% of older individuals might show an Alzheimer's profile, or amyloid imaging showing 28%. These are obviously two different populations. They differed by age. If we use the same biomarker in the same patients, there's generally very good correlation between the spinal fluid markers of amyloid changes and the PET imaging markers of amyloid accumulation. So in general, if you were positive based on an amyloid PET scan, you were also positive based on a low level of beta amyloid in the spinal fluid, and if you were negative on one marker, you were generally negative on the other, although there are some exceptions, typically near the threshold. So this gives rise to the idea that we can see changes in these amyloid biomarkers in individuals simply getting older without any clinical symptoms at this point of Alzheimer's dementia. And this has given us further insight into the natural history of Alzheimer's dementia. So if we look at the clinical change, an individual starts off at this level of cognition. There may be some subtle changes associated with normal aging, but at some point the trajectory changes. They start to develop more notable memory difficulties, but maybe still independent, so a condition we call mild cognitive impairment. But over time, this individual may then transition on to full-fledged Alzheimer's dementia of either mild, moderate, or severe level. By the time we're making a diagnosis of Alzheimer's dementia clinically, it looks like, based on these biomarker studies, that the changes in the brain, as measured by things like spinal fluid or brain scans, these markers that tell us about changes related to plaques and tangles, have actually been going on for many years, back when the individual was not showing any signs or symptoms of dementia. And in fact, if you look at how often you get an abnormal amyloid scan by age, it roughly mirrors the likelihood of someone having Alzheimer's dementia 15 to 20 years later. So again, we may be picking up these very early biological changes before they translate into clinical symptoms. That can make it a challenge because, again, if we're treating individuals at this stage, we're many, many years behind the biological process, but it also gives us the opportunity to potentially intervene here if we can detect those individuals showing early biological changes before their symptoms ever develop. So do we know that, in fact, individuals who have an abnormal biomarker profile, whether it's by PET imaging or MRI imaging or by spinal fluid assessment, do we know whether those individuals with normal cognition who have an abnormal biomarker pattern, are they destined to go on to a clinical diagnosis of Alzheimer's dementia? No, we certainly do not know that. But that's an area of active study to see how well these biomarkers predict the risk of future dementia. So again, if you look at individuals participating in the Alzheimer's Disease Neuroimaging Initiative, those who entered the study with normal cognition, in this particular subset, depending on which biomarker you looked at, if you looked at spinal fluid markers, 40% had an abnormal profile if it was looking at amyloid, 20% if you were looking at tau, and a smaller number if you were looking at MRI. So not all those, the biomarkers seem to become abnormal at the same point in time. If you look at the individuals with mild cognitive impairment, a higher percent of them had an abnormal biomarker. And again, it wasn't the same across the three biomarkers. Any abnormal biomarker increased the risk of these individuals progressing on to dementia over time. But if you looked at when they progressed, those with hippocampal atrophy were more likely to progress in the immediate future, suggesting they were closer to the threshold of dementia using this biomarker compared to some of the other biomarkers. And this has given rise to the idea of a biomarker cascade for Alzheimer's dementia. So again, not every biomarker that may be telling us about Alzheimer's related changes becomes abnormal at the same time. It looks like the markers related to amyloid become abnormal first at a time when individuals are cognitively normal. So this could be by measures of spinal fluid showing reduced beta amyloid, or by amyloid brain imaging looking for amyloid accumulation. And it's somewhat later that measures of tau pathology, whether that's spinal fluid measures of tau, or we do now also have PET images that look for tau accumulation. Those may change later in time. And then only at a further point do we start to see changes in brain structure, like the atrophy measured on MRI. And finally, you start to see clinical changes in terms of cognitive changes in memory and in terms of day-to-day function. So again, when these biomarkers change is not identical across the spectrum, and that may mean that depending on where someone is across this biomarker cascade, the treatments might be different. So if you want to prevent amyloid accumulation, you're going to have to treat very early. If someone already has extensive amyloid accumulation, they may respond to a therapy more geared towards tau pathology, for example. So this is a hypothesis, and it remains to be confirmed with further use of these biomarkers. So in summary, both imaging and spinal fluid biomarkers can help us in distinguishing Alzheimer's dementia from other types of dementia, and also appear, at least preliminarily, to identify individuals who are at higher risk of Alzheimer's dementia in the future. But what the best biomarker is may depend on the exact clinical question. So again, if you're trying to distinguish Alzheimer's dementia from dementia with Lewy bodies, medial temporal atrophy on MRI might be quite helpful, or a PET image using DTBZ. In comparison, if you're trying to distinguish Alzheimer's disease versus a frontotemporal dementia, looking at markers of FDG metabolism or markers of amyloid accumulation may be more helpful, whereas measures of amyloid accumulation would be less helpful in this distinction. Similarly, if you're looking at the risk of progression, and that might favor one biomarker versus the timing of when progression occurs, that might be best determined by a different biomarker. And at the current time, most of these biomarkers are restricted to research use, in part because they're limited by the cost. These PET imaging tracers, for example, are currently quite expensive, and obviously spinal fluid markers do involve some inconvenience of the lumbar puncture. And so there's a great emphasis on looking at other potential biomarkers that may correlate with the spinal fluid and imaging biomarkers, so that ultimately we can get to that simple and convenient, simple blood test, simple test that can really allow us to distinguish these disorders with great accuracy and treat at the earliest possible stage. Thank you very much for your attention.